Hello, everyone. Welcome back to Luncheon with the Experts, the Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and a writer that's been working with CCF for it's 2022 now, which is almost half over, which is wild. So over a decade, 11 going on 12 years, creating all sorts of video content, live video series like the one you're going to watch today, documentaries, patient-centric documentaries, treatment-based videos, all kinds of videos. We've, conferences and events, but all with the same mission in mind, and that is to help spread awareness and education about neuroendocrine tumors. That is what we are here to do. So if you're just signing on, let us know where you are signing on from in the world. Say hello to everybody. If you're new to the show, if this is your first time watching, first of all, welcome. I'm glad you're here. I'm glad you found us. And I encourage you to chime in on the comments section, introduce yourself, reach out, because this show is really, in terms of its value, twofold. One, the information you'll get from our guest today, and two, the camaraderie, the community, the shared experiences and stories from the people within the NET community. I cannot say it enough how much you will benefit from that. They will take very good care of you. So embrace them, reach out to them, say hello, and they will welcome you. Before we get started, we always want to thank our sponsor, Ipsen Biopharmaceuticals, for their support. Simply, we could not do the show without them. And we always have this quick disclaimer from them, and that is that the opinions expressed today by the guest presenters, as well as the questions that you all, the audience at home, ask, haven't been created or suggested beforehand by the sponsors of Luncheon with the Experts, and CCF doesn't endorse or promote any of these views, opinions, or information that will be provided today in the presentation. And audience members should not rely solely on the opinions or information expressed by the guests today, and should seek guidance regarding any from their own medical advisors regarding any choices they make about their health or treatments. Okay, that last line is really the crux of that, the takeaway that I want you to focus on. We're going to give you some good advice, general advice, good, hopefully answer some of your questions, but by no means do we or our guest know your specific case. So take that advice and those answers to your question back to your home team, which does, and make the best plan and path forward for you. Because in the past 10 years, if there's anything I've learned, it's that every case of this disease is unique, and therefore every path and plan moving forward is as well. Okay, so today our guest is, and I'm very excited to welcome back to the show, Dr. Jason Starr, who has been one of our top guests. Spoiler alert, you're going to have a great show today. Dr. Starr, how are you?
I'm great. I'm so happy to be back. It's been a little while, but
Yes.
Loved doing this last time and really looking forward to interacting with everybody.
Absolutely. It has been a little while, and it's kind of wild being in this semi post-pandemic world. It feels like we had a 2-year blip of sorts. It's really hard for me to know, like, was that 2019 or 2021?
Yeah, same
I don't
here.
know. I don't know. It all kind of blurs together. For those that may not be familiar with you, I think that today's show is going to be highly anticipated. But for those who aren't familiar with you and your work, tell us a little bit about what you do, where you work, and the role that you fill in this NET community.
Yeah. So I am a medical oncologist, and I'm at Mayo Clinic in Florida. I did all my training at Mayo Clinic and left for a little bit and found my way back, and really proud of where I work. I have a passion for neuroendocrine cancers, helping patients through their journey. I have research interests that involve, looking at different variables, how we can make treatments better, and personalizing treatments, clinical trials, all things neuroendocrine. We started a support group here in Florida, in Northeast Florida, called the Northeast Neuroendocrine Zebras. So I got to give them a shout out. And, that really, I've always loved education, and I typically would do education, obviously, with patients in the room. And then I love teaching the residents and the fellows and the medical students. But then, that support group really stemmed the love of getting to educate patients on a wider scale. And this is right up my alley. What I always say, and I posted this on Twitter, is I love when my patients become patient experts, right?
Mm-hmm.
And they can guide others, and they, power, knowledge is power. And so if I could give them that and clarify things, and, when I finish up a visit, I'm like, I want to make sure they understand. It's not about me understanding.
Mm-hmm.
I want to make sure they understand. So that'll be really the focus, when I'm trying to answer questions, make sure that I explain things in terms that are understandable.
Lovely. And we appreciate that. I know the patients do too. I think most people do. And that is a skill set all on its own to be able to convey information in a way that people can digest it. So we certainly appreciate that here on the show. And listen, you've alluded to this. You know that the NET community is very well educated, but we get new people to this journey and this show every week. So we'll still try to lay some foundation for those topics that you and I may know easily. We talk about them all the time, but sometimes this is very confusing to people when they're new to this. They haven't heard what these things are, and so yeah, we'll cover all those bases. Folks, I mentioned earlier the work that I've done with CCF over the past 10 years. And so before we move on, I just want to say that I really encourage you to look at the database that we have created. We have quite a library of video content here under the videos tab, also on YouTube. That's countless episodes of Luncheon with the Experts, but documentaries, treatment-based videos. If there is a topic that you are interested in, concerned about, I can almost guarantee you that we've covered it in some capacity. And just coincidentally, we are working on a new documentary series this year. The last one we did was 2018, award-winning documentary series that we follow patients of NET patients and their lives and how they emotionally and psychologically navigate this rare disease. And so just this week, we have a new series coming out this year, probably in early fall. And just this week, I was with one of Dr. Starr's patients, Eileen Bildman. And folks, I just have to plug this quickly. This episode will probably come out, like I said, early fall. Such an inspiration. I'll just give you a quick glimpse. She is a Ferrari race car driver that is a NET patient. There's a lot more to her life, but I don't need to say much more than that. She started racing at age 58. She's now around 65, Dr. Starr, something like that.
Yeah.
Maybe, and races Ferraris. I went to Daytona to film her racing Ferrari. So I'm telling you, when we talk about quality of life with this disease and how to manage it and not let this control your life, her story is one that is going to provide you with a lot of inspiration. I can't wait to bring it to you, and we will, of course, keep you posted on that. So for today's show, go ahead and start sending in your questions. Dr. Starr has kind of let you know a little bit about the areas that he can field questions, which he said nothing is off limits for him. So go ahead and start sending in those in. We may not get to all of them because we're going to have a lot of them. So if we don't, you can always follow up with CCF here on the Facebook page or at carcinoid.org. If you're still on the call and you have a follow-up question, you can always chime back in. Like we said, we can't answer things that are too case specific, but really try to get your questions across. And if there's someone here that you think deserves to be here or forgot about the show or wants to get a question across, go ahead and tag them in the comments. Let them know that the show is going on. And also, if you see a comment in the sidebar that you also have, you're interested in, you can do something that will help me out a lot. Just under the comment, you can like that or love that or any of the emotions that Facebook allows you to use. They all effectively work the same way for me, and it upvotes that question. I see there's a big demand for that question. So as I'm browsing the questions, if I see 8 people have the same question, I'm going to make sure that we get that one across. So it just helps me do my job better, which is, of course, to serve you. Okay, go ahead and start sending in your questions. I've got a few for Dr. Starr, but to get us started, I want to talk about the education component. I love this. We've already alluded to how NET patients, seemingly to me, I may be biased, more than other diseases or other cancers, seem to be super well educated. But let's go back to that patient that maybe got diagnosed last week. Okay. What is that first simple step someone can take to be their own best advocate, as we hear, and to educate themselves in a rare cancer that they may have never heard of before, so that, they don't know where to start? Where do they start?
Yeah. That is a really good question, kind of to set the kind of foundation. I can't imagine how overwhelming it is to be diagnosed with cancer and in a more rare cancer that we consider a rare cancer. Like, where do I start? I think obviously if you're tuning in, you're kind of in the know. But if you're kind of guiding a friend through it or someone through your organization or advocacy group or support group, I think reliable websites are a good start. Carcinoid Cancer Foundation, great start. And there's a lot of reputable websites and organizations out there, because you really want to make sure that the information that you're getting is valid, accurate, because there's a lot of misinformation out there. I don't have to go on a diatribe about that. But that really can send you in a tailwind when you're already in a chaotic time. So that's a good place to start. Now, I do recommend, before you go see the oncologist, the medical oncologist, it is nice to get to see a NET expert, and CCF does list, NET experts in your area, and then have a list of questions to ask, right? Come armed with questions so that, because when you're in the appointment, it's easy to forget what you were going to ask, or the doctor may say something that just throws you off and your mind just goes blank. So what you really want to know is, you want to know, where did the cancer start, right? And that kind of gives you an idea. Okay, where in my body did this start, right? And then you want to know the stage, right? And the doctor may not know the stage right at that moment, just because they may need to do more tests, or surgery may need to be done, a number of variables, but at least the doctor can give you an idea of the stage, right? Then you want to know, is this a neuroendocrine tumor, or is this a neuroendocrine carcinoma? So when I see patients, from other facilities and centers, sometimes the path report will interchange carcinoma and tumor. And it's frustrating for me, because I can't figure out what either the oncologist or the pathologist is saying. But that is a huge branch point in terms of decision making. Okay. And then the grade of the tumor. You want to ask your doctor, what grade is this? There's grade 1, 2, and 3. Gives you an idea of how aggressive the cancer is. And then from there, once you have an understanding of the biology, the basic principles, where did this come from? What does it look like underneath the microscope? How is it going to behave? Then you talk about, okay, should we get for example, dotatate imaging? Do we need to get another biopsy? What's my treatment options? Because if you don't have the foundation of what it is, and you don't properly name it, the treatment is, can be all over the map. And as Rain mentioned, the treatment is so personalized. I have this flow chart of, the approach to some of for a well-differentiated neuroendocrine tumor, and it branches so many different places. There's liver-directed therapy. There's obviously PRRT. There's surgical intervention. So it's so important that you're at a facility that has a multidisciplinary team, right? That has the expertise to know what to do for you.
Perfect. I love the flowchart idea too. That's so helpful to visualize the journey of the story. And yes, folks, speaking of multidisciplinary teams, there's a video about that as well that we have. If you can't tell already, folks, this is going to be a good episode. I told you that it would be. Dr. Starr is awesome. Our turnout's looking great. I think his last show was one of our top performing shows of all time. Let's make round 2 as one as well. We've already got over 100 people in the room, so that is a great sign. We've just started. Brian from California says, just got done with Somatostatin injections, and I'm on time for the show. Great to hear that. We're happy to have you here, Brian. Let's start taking some questions. Lynn says, so much is being done to kill the diseased cells and repair the damage NETs has caused. What is being done in labs and trials to fix the mutated DNA/genes to get people back to normal?
Yeah. I think that question alludes to gene therapy. Gene therapy is very complex. We've looked at it. They do have an FDA approved gene therapy to repair a condition in the eye. And essentially what is done is there's an injection where you have a vector, which is a virus that reinserts the DNA to what it's supposed to be. And there's so many layers and so much complexity on how to do that. Now, for cells that are damaged, right? Our body has unbelievable regenerative capacity, right? And sometimes when I can't figure out what's going on with a patient outside of NET, sometimes the body just fixes itself, and I don't need to figure it out because the body just fixes it. So the cells that are damaged, if there's not an inherited DNA problem, right? You didn't inherit a DNA mutation from mom or dad, which is the minority of patients. So when patients present with a cancer, only about 3 to 5% of cancers are from inherited genes from mom and dad. Most of the DNA damage occurs after, our DNA is determined from mom and dad, right? We have 23 chromosomes from mom, 23 chromosomes from dad. They come together, there's 46 chromosomes. And they're usually not altered to lead to cancer. Okay. So over the course of our lives, due to any number of reasons, environmental, and so on and so forth, the DNA can become faulty, right? And a mutation occurs. So your cells that are damaged by whatever treatment, as long as they don't have the mutations present, they will repair themselves. So I think what I'm getting at is the body's own regenerative capacity will repair the cells that are not inherently already damaged. And that's the whole principle behind chemotherapy, right? We damage the cells that have a DNA problem because they're dividing uncontrolled. The cells, the collateral damage for the normal cells, they take care of themselves. They regenerate normally. So I think as we look at new therapies, we try to spare normal cells and normal tissue as much as possible. And that's how the newer therapies, for example, PRRT, which I'm sure we'll get around to, they exploit a receptor that is not only on neuroendocrine cells. It's not only on neuroendocrine tumor cells, it's also on other neuroendocrine cells, but many cells in our body don't have the receptors. So we're sparing a lot of our normal cells from getting exposed to the radiation. So those are ways that we try to overcome and make sure we don't damage good cells.
Got it. Thank you. Thanks, Len, for your question. Next question from Deborah. I was diagnosed 4 years ago with lung nets. I have severe anemia, and I was told I have a gut bleed. I get octreotide once a month for 4 years now. How are these related, if at all, and how are they treated?
Yeah, great question. So they would not appear to be related. GI bleeding can be the first presenting signs of a neuroendocrine tumor, particularly when we see it in the small bowel and the terminal ileum. Some patients present with persistent iron deficiency anemia, and then we find this tumor that's been bleeding. In this situation, when it started in the lung, there wouldn't be a correlation between the neuroendocrine tumor in the lung unless there's a neuroendocrine tumor in the gut that hasn't been identified, which I have seen patients with a neuroendocrine tumor in the gut and the lung that are completely separate. I have one patient like that right now. So usually when there's bleeding in the GI tract, we do something called endoscopy. So we'll do an upper endoscopy, which we call an EGD, and a colonoscopy, which is from the bottom. And then I just saw a patient like this today. Those are normal. So now what do I do? So there are other things such as something called a pill cam endoscopy, where you swallow a little camera.
That's what Eileen had, right?
Yes, exactly.
Yep, we talked about that. Yeah.
Yep. So you swallow this little. Now that the fidelity, it's not a perfect test because it misses some things. Well, then they came out with something called a double balloon enteroscopy, which is a way to telescope through the small bowel, which is amazing. We could never really visualize the small bowel directly before. And I just recommended one for a patient today who has unexplained iron deficiency anemia where we can't find the bleed. So I would recommend talking to your physician about, trying to, figure out where the bleeding is coming from. There's also something called a tagged red blood cell scan, which they can actually tag your red blood. They inject you with red blood similar to PRRT, but they inject you with red blood cells that are tagged with a radio tracer, and then they can detect where the bleeding is occurring in the body with a nuclear scan, which is incredible. But the bleeding has to be at a certain rate to detect that. So long story short, there's a lot of ways to determine where bleeding is occurring in the GI tract.
Thank you very much. And thanks for your question, Deborah. Next question from Eva. Eva says, hi, Dr. Starr. A friend asked this on a net page yesterday. A few other people have this question. Could high liver enzymes be indicative of liver tumor growth?
That's a great question. So typically, no. The liver, we talk more about regenerative capacity. The liver has an unbelievable regenerative capacity. You can literally remove half the liver and it will grow back to almost where it was before, which is incredible. So if there are tumors within the liver compensates for the space that is being taken up by those tumors. When we can get into problems is when the tumors may be growing at a rate where there's not much normal liver tissue. And in that case, that's when we would start seeing elevated liver enzymes. So it really is determined by what we call the burden of disease in the liver. And if the burden is very, very high, then the liver enzymes can go up. But if the burden of the disease is low to medium, usually we won't see elevated liver enzymes. So then you start looking at medications, screening for hepatitis, especially the baby boomer era. Everybody should be screened for hepatitis. And you start looking for other reasons. Another reason for elevated liver enzymes that's sometimes under-recognized is non-alcoholic steatohepatitis, which we also call fatty liver. So that's an increasingly common condition in the westernized world because we tend to be a little bit more overweight. So that's under-recognized and a very common cause.
Awesome. Thank you. That was a thorough answer. I appreciate that very much. And great question. Great questions already from everyone.
Absolutely.
From Katie, is it ever beneficial to have liver debulking surgery and or surgery on a primary rectal tumor if high grade stage 4 with heavy tumor burden on the liver?
Yeah. So surgery on the liver has been an area of interest for, as long as I've been doing this, and long before that. The principle in neuroendocrine tumors is that if you have liver predominant disease and you can clear at least 70% of the disease, and typically we're talking about bowel, typically small bowel neuroendocrine tumors that metastasize to the liver. If you can clear that much, that might be a beneficial intervention for the patient. What you really have to consider is what disease is outside the liver. Because if you're just addressing the liver, it's not going to make much of a difference if the disease outside the liver is progressing or is substantial. So it's really in situations where you have liver predominant disease, where the rest of the disease is stable, and that you're going to have enough liver left behind to be able to function. As I mentioned, you can be left with 30% of your liver and be just fine, pending that you didn't have liver problems prior to that. So the answer is that if there's diffuse involvement of the liver, then it's typically not beneficial to do a surgery, debulking.
Got it. Thanks, Katie. Hopefully that helps. Angel says, I'm new to this journey with my husband. Angel, well, I'm sorry to hear that, but I welcome you and I welcome you to the show. I'm glad you found your way here. And as I said in the beginning, you may have heard this or not, definitely embrace the community, reach out, make connections with people, but I'm happy you're here. Please keep coming back. Next question. Okay, this is a good one from Katie. Also, which immunotherapies are currently showing the most promise for high-grade neuroendocrine carcinoma? And several other people are interested in this as well.
Oh, great question.
Right.
Yeah. So we talk about this a lot. I just was involved in a kind of a committee trying to develop some education for other oncologists for this topic. That is the high-grade neuroendocrine carcinoma is the patient population where we saw some promise. So there was a study called the DART study, D-A-R-T, and it was really for rare tumors, right? So neuroendocrine carcinoma would be considered a rare tumor. And what they did is they gave 2 immunotherapy drugs, and they looked at how they did. So patients with neuroendocrine carcinoma were some of the patients who benefited the most. The problem with the study is that it was very heterogeneous, meaning there were neuroendocrine carcinomas from the lung, from the bowel, from the pancreas, from gynecological organs. So it was really a mixed bag. And what we know is that really they're very distinct diseases, right? When it comes from the lung, it's different when it's from the bowel. So it was hard to make any definitive conclusions. Now, here at Mayo Clinic, we looked at our own experience. And so the response rate reported in that study was around 40%. What we noted is that our response rate was 10% or so. So we saw much less benefit than was reported in that study. Now we're looking at whether or not there are features of the genetic makeup of these tumors, 2 genes, one called P53, one called RB. And what we noticed in our data is that when the 2 are mutated, patients tend to have benefited more from the immunotherapy. So I will say anecdotally, when I've used immunotherapy and neuroendocrine carcinoma, it's been a little disappointing. So I still think there's a lot of work to be done to determine which patients will benefit from the immunotherapy. Now, DART did an expansion of their study to look at more patients because they had that signal. And I believe that might still be going on. So they're still enrolling patients to confirm or deny that that was real signal. I hope that answered the question.
Got it. Me too. And if it didn't, and this goes to anyone asking the questions, if a question creates a follow-up question, or if we didn't quite understand, you can always chime back in. Give me a little bit of context because I get so many questions, like to remind me of your previous question. Just clarify, and we'll try to get to the bottom of it. That's what.
And Rain, I'll just specify real quick.
Yes.
So ultimately, to date, immunotherapy has been disappointing for neuroendocrine cancers.
Got it. That is disappointing to hear. From Pam, after second PRRT, my husband's tumor and my husband's tumors have grown. We may be facing to choose between Afinitor and Y90. We have done most everything else, and he has multiple metastases. The question is, which do you prefer?
Yeah.
Which I know is probably hard to say, but like, let's talk about those 2 options.
Yeah. That's a really tough situation to be in. I'm sorry for your husband, to go on a therapy that's really promising and not see benefit. I will say that there are some situations where we can see potentially a flare in the disease where you see some growth, but it's actually related to treatment response. We don't understand that fully, so I don't want to speak. I'm just speaking in generalities here. But if you start seeing new disease in the middle of PRRT, it's very clear at that point that there's progression of disease. And I've been in that situation a few times. So it really, what really hinges here is what type of neuroendocrine tumor this is. So is it a small bowel neuroendocrine tumor, or is it a pancreatic neuroendocrine tumor, which are the more common ones that we're dealing with. If it's a small bowel neuroendocrine tumor, the everolimus or the Afinitor is going to be more of a systemic treatment, meaning it's going to address the disease all over the body. The Y90 is only going to address the disease in the liver. Now, there are situations where you might combine those, depending if the liver is really the predominant area of progression. But you also want to address the rest of the disease. You can use the Afinitor. Now, if we're in the pancreatic neuroendocrine tumor realm, a better option may be capecitabine and temozolomide. That's really a go-to for pancreatic neuroendocrine tumors. maybe even before Afinitor. So that's a consideration that I have for patients, but I think it really depends on where the neuroendocrine tumor. That's why we talked about, at the beginning, the foundation. Where did it start? What's the grade? This tumor sounds, a bit aggressive, and so it may be a grade 3 tumor. And as we do have some data for grade 3 tumors with PRRT, but I will note the majority of trials to date have excluded grade 3 for PRRT.
Got it. Thank you. Hope that helps, Pam. Thanks for your question. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We're here with Dr. Jason Starr from Mayo Clinic in sunny Florida, the Jacksonville area. Okay, so I knew I would get this question today from Jim. Any updates on Novartis and Lutathera? And just to lay a little bit of groundwork, there was a disruption in the production of Lutathera by Novartis in US and Italy, I believe. You can explain more if you want to, but a few other people obviously are interested in that too. Any news?
Yeah, so this has been a big disruption. I just got an email this morning from the NANETS, which is the North American Neuroendocrine Tumor Society, the president, which is Dr. Jonathan Strasberg, who we've had here before. And it was trying, I think they did NANETS did a brief webinar on the disruption, which I haven't watched yet.
Okay.
Essentially, they're saying 4 to 6 weeks is going to be the disruption. And we don't know what happened yet. We don't know why there was a disruption. Obviously, the radiopharmaceutical has to be developed in something called a cyclotron. They have to have the lutetium-177. So I don't know if there was a shortage with that. It's been really nerve-wracking and anxiety provoking. I mean, you're in the middle of treatment and it's getting delayed. You want to start treatment and we don't have it. There's clinical trials that are depending on the commercial Lutathera to continue to go. So it's just a reminder of there's so many variables and components that are outside of our control. I hope I get some more clarity, but last I was told 4 to 6 weeks until they're back up and running.
Well, yeah, that is frustrating, but I appreciate you giving us some insight on that. Another great question from Katie. She says, I know that neuroendocrine cancer are all the same type of cancer. So why are the different primary locations treated differently?
Yeah. So it is true that all of the neuroendocrine cancers are derived from neuroendocrine cells, wherever that is in the body. However, what triggers the cancer? What DNA damage event that triggers cancer is typically different wherever in different parts of the body. For example, I alluded to neuroendocrine carcinoma, for example, of the colon. We'll see P53 and retinoblastoma, the RB mutations. But in pancreatic neuroendocrine tumors, the well-differentiated type in the pancreas, we'll see mutations in MEN. We'll see mutations in a gene called ATRX. So although they derive from the same cells, what triggers carcinogenesis, what triggers the development of cancer is different. So that's why they behave differently, and that's why the treatment approaches can be a bit different.
Great answer and great question, Katie. All of your questions today, Katie, have been awesome.
Awesome. Yeah.
From Nat, I know lanreotide is used for helping slow the growth of tumors. Is octreotide as effective? I've heard that it may be as effective with less side effects. So the question is, why would one use one or the other?
Yeah. That I love that question too. Very insightful. So, the octreotide or sandostatin or the lanreotide or somatostatin depot, they hit the same target. They hit the somatostatin receptor on the cell, right? And when they hit the target, they send inhibitory signals through the cell to stop dividing. And that's why, as the question alluded to, it slows down the cells. So the differences right now is lanreotide is given as a deep subcutaneous injection. Sandostatin or octreotide is given as a intramuscular injection. I'll hear variable things from patients in terms of, one is more painful than the other, one's less painful than the other. The pharmacokinetics, which I don't want to get too much into the weeds, may be a little bit different between the drugs, but ultimately they are sister drugs. And I think both of them are reasonable. I don't see, a huge advantage of one or the other. Cost always comes into the picture. I think that the delivery system for the lanreotide, the way that the drug is given and the way that the nurses say that it's easier to give. So I think the lanreotide does have an advantage in that regard. The one other thing is that you can ask your doctor and I'm getting a little bit off topic, but I want to mention it, is you can ask for lidocaine patches or lidocaine cream to put on the area that they're going to inject. So if you know which side of the buttocks they're going to inject, you put it on maybe 30 minutes to an hour before. It'll numb the area so that the injection is not painful. So that's always a trick. And I love mentioning it because some patients, it really makes a big difference. But to answer your question, if your doctor chose sandostatin or your doctor chose Somatuline, I think that either one would be reasonable.
Got it. Thank you. Moving on. Next question from Faith and seemingly a few others. And we get questions about this often. I have 3 family members with NETs. Is there a DNA test to check for others in the family?
Yeah. So the DNA, the syndrome, the inherited genetic syndrome that we think about the most when we relate to neuroendocrine tumors is something called MEN syndrome, or multiple endocrine neoplasia. And that typically is a pancreatic neuroendocrine tumor in somebody who also has high calcium or something in their pituitary gland, or a family history thereof, right? Now, Dr. Perez at Harvard has done some work and looked at a series of patients who had neuroendocrine tumors and did some genetic sequencing and determined that, I believe it was like 3 or 5% of patients, it wasn't a big group, had a genetic syndrome in small bowel neuroendocrine tumors. So that is not something I had considered really before. So if you have a strong family history of neuroendocrine tumors, I don't think it's unreasonable to, it's got to be like, first degree relatives. I don't think it's unreasonable to get genetic testing, or at least talk to a genetic counselor about your risk. And that's not something I was thinking about until I saw that abstract. And I think that was Dr. Perez published that. I think I saw that publication.
Got it. Thank you. Next question from Angel, who we said hello to earlier, who's new to the show. If you have the NET removed, do they come back? My husband's NET tumor was in the small intestine and he had a partial hemicolectomy. Had a PET scan with gallium, and PA said no more sign of cancer. So what do we do? Like she says, we just feel so lost right now.
Yeah. So typically when I see patients after surgery and I'm counseling them on like, where do we go from here? We talk about potentially the risk of recurrence. The risk of recurrence is based on the stage. And that's why I mentioned when you talk to your oncologist, you want to talk about what the stage of the disease is: stage 1, stage 2, stage 3, stage 4. So if it was resected and you had a stage 1, 2, or 3, obviously the chances go up the higher the stage. And stage 3 indicates that there was lymph node involvement. So that's kind of how we assess risk of recurrence. Now, if you look at the data, even with lymph node involvement, the risk of recurrence still can be quite low, 20, 30%, which easy for me to say, but still anxiety provoking on the other side. when you're sitting on the other side of the exam room. So what we recommend typically is scans. I typically, for a grade 1 or grade 2 tumor, I typically do scans about once a year. And I will follow patients with imaging to evaluate for any evidence of recurrence. It's very important that the oncologist orders what we call a triple, if they're going to order a CT scan, triple phase of the liver, because you need the arterial phase of the liver to evaluate for any metastasis that could spread to the liver. So that's one point. The second point is that for most cancers, we follow patients for 5 years before we consider cure. We have data suggesting that recurrences for neuroendocrine tumors can occur as late as 10 years or more, but we recommend monitoring patients for 10 years. Sometimes what I do to minimize radiation exposure is I will do alternating CT and MRI, so that to limit the radiation exposure from the CT scan. So I know you feel lost and you're like, well, what do we do now? Ultimately, I hope that the surgery was a curative, and so I hope that you guys can kind of get on with your lives and go to the doctor for checkups and try to put this out of sight, out of mind, best you can.
Got it. Thank you, Angel. I appreciate you chiming in. From our friend Wendy. Wendy says, can you have more than one liver resection?
The answer is yes. Because the liver is so regenerative, you can.
Got it.
Yeah, that was my shortest answer.
Yeah, no, perfect.
Usually they're a little more drawn out.
Any criteria that determines, or?
Yeah, so as I had mentioned, you typically want at least 30% remnant liver. So if you're going to do a resection, we do something called volumetrics. So we measure the volume of the liver, and we can determine with the resection how much volume is going to be left. And that's how we determine if it's feasible. Sometimes we do liver resections in staged approaches. So we'll, this is getting a little bit more, now I'll get long-winded. We'll do something called a radioembolization to the left lobe. And what that allows is for the right lobe to grow, and then do a formal resection potentially of the left lobe after the right lobe grows a bit. So there's a bunch of different ways, but ultimately the liver, can tolerate multiple surgeries, and it's an amazing organ.
Got it. Thank you. And thanks, Wendy. Good to see you. Cindy says, I'm NED, no evidence of disease, for 5 years. Yeah. For 5 years post Whipple surgery for PNET stage 4 to liver. So that's good news. Right.
Awesome.
My concern is surveillance options due to insurance policies. I can no longer get PET or MRI scans. And at this time, I have chromogranin and serotonin labs twice a year, and 3-day octreotide scan once a year. I would like to know simply if there's a better surveillance plan. Is there something else Cindy should or could be doing? Yeah.
I just had to do a peer-to-peer, which is where you call the insurance company and kind of advocate for the patient on this. I do not do PET scans for surveillance, and I don't advocate to do PET scans for surveillance. I don't think that they really help all that much, and they're super expensive. And so I could understand why the insurance company would give pushback on that. At 5 years, being 5 years out, I think that once yearly surveillance would be reasonable at this point. I think the risk of recurrence, the risk of recurrence decreases, obviously, the further you get out from the surgery. So I think that, once yearly. Now, CT, MRI, again, you can alternate them. If the insurance company is giving a lot of pushback on MRI, once a year CT would be reasonable, and the radiation exposure would not be significant to the point where I'd be worried. I do see some outside oncologists outside of my practice ordering the PET scans, and it's a bit too much. But I am a man of compromise, and I want to make sure my patients are comfortable. So we do have a discussion. I'm not black and white about it. I'm not dogmatic about it. We talk about it.
Got it. Understood. Next question from our friend Karen. Karen says, I've been off treatment for 9 months now, just supplements. And however, the last scan showed slight growth with tumors. There are tumors in the liver, spine, mesentery, small intestines. The question is, what treatment would you recommend? Which I know is a big, broad question, but let's talk about some options for
Yeah.
Karen.
Yeah. So I don't know if you had mentioned where it had started. No, not in there. Okay.
Not in there.
It sounds like a small bowel neuroendocrine tumor based on the pattern, the distribution of the metastasis.
Okay.
The starting point is the somatostatin analogues. So the Landriate or the octreotide LAR.
Mm-hmm.
And did the patient have that already?
No, but I'm familiar. Karen, let me know if I'm messing this up, of course. But if those aren't an option, I feel like I remember her saying this in previous weeks.
Yeah.
Or no, or is it that you don't have receptors? I don't want to speak out of turn, but keep going, and then give me something that just considers if those aren't an option.
Yeah. So if those are an option, if the PET scan's positive, then the somatostatin analogs. If they're negative, then you really have to reconsider, what you're doing. Negative is a rare situation. We think that, the sensitivity of the dotatate scan is like 90 is very good, 95%. And the receptor positivity is 98. Maybe there's 2% of patients with these small bowel nets or PNETs that aren't somatostatin positive.
Mm-hmm.
So if you're in that small percentage that are negative, you worry about that it might be a more aggressive type of cancer, because when those tumors lose their receptors,
Mm-hmm.
it indicates sometimes that the disease is a bit more dedifferentiated, that the cells can't figure out what they are. And when cells can't figure out what they are, the cancer can tend to be more aggressive. So I would determine, first, is this a neuroendocrine tumor or a neuroendocrine carcinoma? So I would make sure that that is very clear and spelled out, that the medical team and the patient are on the same page regarding that. For patients who are somatostatin negative for small bowel tumors, you still have the options of the everolimus, right? Then it gets a little bit, the options become much less, right, for small bowel neuroendocrine tumors, because you don't have another FDA approved therapy. And so at that point, you really start looking at clinical trials. I'm going to do a plug for the Cabinet trial, which is a trial that's going on throughout the country. Dr. Jennifer Chan is the principal investigator over at Harvard, and we're studying a drug called cabozantinib. And so this patient would potentially be a candidate for that trial. On the flip side, for the pancreatic neuroendocrine tumor, again, if it's a somatostatin negative tumor, you still have the capecitabine, temozolomide, okay? You still have the everolimus or the Afinitor. And then you have also another group of drugs called tyrosine kinase inhibitors. So the FDA approved one is sunitinib or Sutent, right? And then there's one that has been submitted for what we call fiduciary for review by the FDA, called surifatinib. So that's on the horizon. That's another tyrosine kinase inhibitor. We don't have one approved for small bowel cancer, but hopefully that changes in the near future. So it is true, if the tumor is somatostatin negative, so PET negative, the options decrease because you don't have the somatostatin analog as an option, and you don't have PRRT as an option. So it's a tough situation.
So I have kind of a follow-up question, I think, to that from Jim. It says, if I do not have the somatostatin receptors, taking PRRT off the table as a viable treatment option for liver nets, why would Landriate injections, which I'm getting every 28 days, be viable if that also relies on somatostatin receptors?
Yeah, that's a great question.
Just happen to have that.
Yes. So there's varying degrees of uptake or somatostatin expression, right? So when we do a PET scan, we do grading of the level of expression. We call it the Krenning score. There's grade 1, 2, 3, 4. When you get to grade 3 and 4, that's where you're like, okay, patients will benefit from PRRT. But say you're a grade 2, we typically wouldn't say that patient would benefit from PRRT but clearly the receptors are still there. So the receptor expression is on a spectrum. One way that you can determine if there is somatostatin expression is on the biopsy. You could do a somatostatin receptor stain, because sometimes, although the PET scan's negative, the somatostatin stain on the cellular level is positive. Now, say that it's stone cold negative on the PET, and say that the stain on the tissue is negative. I don't have a good rationale for giving the lanreotide other than if the patient has carcinoid syndrome.
Got it. Thank you.
Sure.
Folks, we got about 10 minutes, just shy of 10 minutes left. Lots of questions. We're going to try to get to as many as possible.
I'll try to do rapid fire. I'll be shorter winded.
There was one that I had that several people had. Where did that go? Allison says, what about a clinical trial versus everolimus or everolimus?
Yeah. So there's a clinical trial that's comparing PRRT versus everolimus. So that's an interesting one. Is called the COMPETE trial. So that's one to look for. I think a clinical trial, generally speaking, is always a good idea. I think that it is the only way that we advance science, right? And I know I don't want to sound like, oh, you're going to be a guinea pig, right? And we're testing something, and because the trials are just designed differently. If you're not going to get a placebo, right, you're still going to get the standard of care, but there's a chance you might get something better. So I think almost invariably a clinical trial is the way to go.
Got it. Thank you. Yeah, I found the one I was looking for from Linda and about 6 other people. Do the tumors get neutral to the injections of lanreotide or octreotide, meaning it does not work anymore eventually?
Yes. We've shown that the injections work for a median, I believe, if I'm not mistaken, about 18 months. But I have had patients on them for 15 years. So clearly there's a lot of variability there. But generally speaking, the disease tends to progress and stop responding to the injections.
Got it. Thank you. From Bill, who says, thank you for this opportunity to ask questions. Absolutely, Bill. That's what we're here to do. Should someone have surgery to remove the small bowel tumor if you are already stage 4 with a small grade, slow growing tumors in lymph nodes?
Oh, this is such a good one. This is one of the topics that we're going to talk about among medical oncologists. So at the doctor level. And so good this question, is Bill. Such a good question. There really is no good data to suggest removing the primary tumor improves outcomes. The situation where I would consider removing the primary tumor is if the primary tumor is causing symptoms, i.e. bleeding, i.e. obstruction, i.e. abdominal pain that may be intermittent obstruction. In that case, I would advocate for removal of the primary tumor.
Got it. Thank you. From Angel, during my gallium CT scan, a moderate SVU of 9.8 was noted in the pancreas, the tail of the pancreas. I was told that this is normal. Is this normal? I had 6 tumors removed from the ileum.
So not normal. The tail of the pancreas gives rise to the spleen. The spleen has lots of somatostatin receptors, tons. It's so bright on the PET scan. Sometimes there's something called a splenule, which is a baby spleen. And so the baby spleen lights up. And so that may be what they're seeing. What I would recommend is an MRI of the pancreas in this setting to determine if there is anything in the pancreas, around the pancreas. Now, there is physiologic uptake, normal uptake in what we call the uncinate process of the pancreas. That's more towards the pancreatic head. And so when you see uptake there, that's usually physiologic, normal. But at the tail, needs to be sorted out.
Got it. From Dana, my husband's last CT scan indicated that some of his liver mets are necrotic. Is that an indication that the Landriate is shrinking / killing the tumors, or is his body attacking them?
Yeah. So necrotic means really that the tumor's essentially either outgrowing its blood supply, or that the therapy is very effective and cancer cells are dying and just becoming cellular debris. Because the somatostatin analogues are not cytotoxic, meaning they really do not destroy cancer cells. They slow them down. I would be concerned about necrotic areas if they weren't there previously, that might signify progression of the disease. And again, I don't know the full situation, so sure. I don't want somebody going back to their oncologist be like, there's something bad going on.
Right.
So the context is important, but that's how I generally think of necrosis.
That's a good point.
Either the treatment's working really well, or the cancer is growing.
From Fernando, I had primary in pancreas, metastasized to the liver. Is an MRI better than a CT scan to keep an eye on it? And then the question really is, why do doctors do one and others use the other?
Yeah. So I really like MRI and spoiled in that sense, because there's something called diffusion weighted imaging, where that gives me such good visualization of the liver. Now, it's more expensive, takes longer. So I think you could use MRI in special circumstances, like the initial diagnosis. But for example, surveillance after a surgery, I think a CT is very reasonable. The pictures are good. But again, I will emphasize, you need triple phase, because you need the arterial phase to determine if there's anything going on in the liver. So I think some doctors have a preference of one or the other. I typically like MRI if I'm trying to sort something out, right? Or I'm trying to monitor treatment response and I need really, really good pictures. But if I'm doing surveillance, CT is more than fine.
Got it. Christy says, how do we know in advance when these live shows are coming up? Christy, same time every week, 12 noon Eastern time to 1 p.m. Every Thursday. We're here. For Fernando, a follow-up question from him. Who do you recommend at Mayo in Phoenix, if you know what to do?
Yes. So Dr. Bassam Sonbol, Sonbol, phenomenal.
Got it. Lovely. I hope that helps, Fernando. Thanks for chiming in today.
Great questions.
I know. Such good questions today. Okay. We've got a minute left.
Yes, let's do it.
A few questions. Where are things right now? I know I've been working with CCF for 10 years. A lot has happened in those 10 years. We've talked about some of the clinical trials today.
Yeah.
And some of the work that you're doing. But what are you looking for next to help make the next leap and bound forward in terms of either how we diagnose this disease or treat this disease?
Yeah.
And I know there's a lot of activity going on right now. So kind of the question is, what is exciting to you? What are you hopeful for in this moment? So
I'm hopeful that we can understand a little bit more of the molecular underpinnings of the cancer. Why does it start? Who's at highest risk, right? What are some of the genetic factors, or what we call epigenetic factors? Like, or, how can we identify this earlier? And is there a blood test? Is there something else that we can use to identify the disease at an earlier stage, right? Because the incidence has been steadily going up. And I don't know that we can explain that just based on improved imaging and whatnot. PRRT, I think new iterations of PRRT, because that's been a breakthrough. So one iteration is allowing the existing PRRT that we have, the Lutathera, work better by giving something called radiosensitizers. So helping the radiation work better. Dr. Aman Shahan, who you had on the show recently, is working on that tirelessly, and he is a brilliant guy. Also, there's something called alpha therapy, alpha particle. So alpha therapy is the same technology, same idea as PRRT, but a different radionuclide, a different energy. So Lutathera is beta energy, and this is alpha therapy. Alpha therapy causes double-stranded DNA breaks. So I'm looking for improvements upon PRRT. Thirdly, and lastly, immunotherapy. I said it's been largely disappointing. We have to find a way to engineer the immune system to recognize this disease, because it's been a breakthrough for so many other diseases. We need that for our patients.
Awesome, folks. That is our show for today. I hope that I lived up to the word, my proclamation in the beginning of the show that this was going to be a great one. It seems from the comments, which we'll send you tomorrow, Dr. Starr, that is true. Thank you for being back here with me. It's always such a pleasure, and I really appreciate you so much and your insight and the way you explain things. Thank you very much.
Thank you. You're a great MC, and I'm happy to do it anytime.
All right. I appreciate that as well. And thanks to you at home. As always, we can't do the show without you, and we appreciate you being here every week. And as always, we hope that this program helped answer some of your questions and give you a little bit of guidance. And I'll reiterate one more time, if you have follow-up questions, please reach out to CCF. This is our job. This is their job. They will get you the information that you need, or the person that can get you the information you need. You can message them right here where you are on Facebook, or you can reach them at carcinoid.org. And also, as soon as this video is done, it will post. It will be under the videos tab. It will be evergreen and live right here on Facebook starting Monday. We'll put it to YouTube for those people who don't. So you can always watch the replay. And if you are new to this disease, I'll also reiterate one more time, browse through the library, the database of videos we have. There is a ton of information that can be helpful for you. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone.